Hello friends, today we are going to discuss regarding the cervical spine, mainly its anatomy in brief and also cervical disc prolapse. So starting with the anatomy, there are in all 7 cervical vertebrae in the human body, out of which 4 are known as typical vertebrae and 3 are known as atypical vertebrae. Typical vertebrae have some features in common, while the other three, that is Atlas, that is C2, Axis, that is C1, and the C7, the vertebra prominence, have some different structures. So the thing which we need to remember is C3 to C6 vertebra are typical vertebrae, and C1, C2, and C7 are known as atypical vertebrae. So any vertebra in between the two vertebrae, there is the intervertebral disc. So this portion, this is your vertebral bone, this is your cervical vertebral bone, and in between this part is your intervertebral disc. So intervertebral disc has two parts. One is the central part, that is this is known as nucleus pulposus, and the other part which is surrounding it, this is known as annulus fibrosus. Central part is known as nucleus pulposus, which is mainly a type 2 collagen. It consists mainly of water, it's 80 to 90% of water. It also has proteoglycans, and that is 60 up to 65%. The function of proteoglycans is to act as a gel-like material or shock absorber. Then surrounding the nucleus pulposus, this is the cut section. This is nucleus pulposus. Surrounding it is this part. It is your annulus fibrosus. It is made up of type 1 collagen. It is covering the nucleus pulposus from all sides, and annulus fibrosus also consists mainly of water, but it consists more of collagen. So it acts as like a covering for nucleus pulposus. So what is the function of intervertebral disc? Intervertebral disc acts as shock absorbers, mainly with the nucleus pulposus. It also acts by holding the ligaments together. It allows compressive, tensile, and rotational motion. So this is your intervertebral disc. So it will act as a shock absorber when the forces are transmitted from here or here. So you'll have more discs here also and here also. Then coming to our main topic, that is cervical disc prolapse, or it is also known as cervical PID, that is prolapse intervertebral disc. So it is more common in males. Males have a 1.4:1 preponderance over females. So factors associated with injury are anything that leads to increase in the pressure in the cervical spine. So most common will be frequent lifting of heavy objects on the head. Then cigarette smoking leads to degeneration of proteoglycans in the nucleus pulposus, and frequent diving from a board, that can also lead to cervical prolapse intervertebral disc. There are 4 stages to disc herniation. This is common in both cervical spine and thoracic spine or in lumbar spine. So first stage is degeneration. There is degeneration of the nucleus pulposus and the annulus fibrosus. So there is a tear or a rent that is starting to appear in degeneration stage. In prolapse, the nucleus pulposus is still surrounded by the annulus fibrosus, but the nucleus pulposus starts migrating and pushing the annulus fibrosus outside. In extrusion, the nucleus pulposus is not surrounded by the annulus fibrosus. There is a tear in the annulus fibrosus. And in sequestration, the nucleus pulposus, some part of the nucleus pulposus is fallen off and it has no connection with the parent body, as you can see here. Then coming to the types of prolapse, there can be 4 types. There can be a central disc herniation. So here will be your spinal cord. So if there is a central disc herniation, it will lead to spinal cord compression. It can also be a posterolateral disc herniation. So here are your nerve roots. So posterolateral disc herniation generally leads to nerve root compression. It can also be a foraminal compression. See, this is your foramen. The hole which you are seeing in between two vertebrae is your foramen. So this also leads to nerve root compression. Or there can be extra foraminal compression. It can also occur here. This is extra foraminal compression. So there are four types: central, posterior, lateral, foraminal, and extra foraminal. So common sites of cervical disc prolapse is C5, C6. It is mainly at C5, C6 because it is the most mobile segment of the cervical spine. And in older patients, C6 to C7 prolapse also occurs. So there are in total 7 cervical vertebrae, as you can see here, from C1 till C7. In between 7 cervical vertebrae, there are 6 intervertebral. There is no disc in between C1 and C2. So leaving that, there is a disc in between every other two vertebrae. So there are 6 intervertebral discs. And the first cervical nerve root exists between the occiput and the C1. Here will be your occiput. Occiput means your head. So in between your C1 and your occiput is your cervical nerve root. That is the first cervical nerve root. So second cervical nerve root will be in between C1 and C2. Between C2 C3 will be a third. Between C3 C4 will be a fourth. Between C4 C5 will be a fifth. Between C5 C6 will be a sixth. Between C6 C7 will be a seventh. And between C7 T1 will be your eighth. So there are in total 8 cervical nerve roots and 7 cervical vertebrae. So cervical disc prolapse is usually posterolateral. See, this is your disc. So here will be your posterior longitudinal ligament. The posterior longitudinal ligament is very strong. So your disc prolapse is generally posterolateral. Coming to clinical features, there will be neck pain radiating to the arm or chest, as there will be nerve root compression. Neck pain radiating to arm or chest will be your most common complaint. Due to nerve root compression, there can be numbness in the fingers. There can be motor weakness of the arms. It can mimic a cardiac disease like angina. And if there is vertebral artery compression, there will be vascular symptoms like dizziness, tinnitus, blurring of vision, and retroocular pain. Patient will complain of restricted cervical spine movements, and the head is often moderately flexed and tilted towards the site of the pain. Or it can also be tilted occasionally away from the site of the pain in other patients. If the disc herniation is long-standing, there may be weakness and wasting in the appropriate muscle groups. So coming to specific nerve roots, if there is a C5 cervical nerve root compression, there will be weakness of the deltoid and the biceps, and there will be sensory loss in the upper lateral arm and elbow. And the reflex which will be lost is bicep reflex. So your muscles that are supplied by C5 will be deltoid, your biceps, this will be your sensory area, that this will be gone, this area, and the bicep reflex will be gone. In your C6 nerve root compression, there will be weakness of the biceps and the extensor carpi radialis brevis and longus tendon. And there will be sensory loss in the lateral forearm, thumb, and index finger. The reflexes that are affected are biceps and brachioradialis. In C7 nerve root compression, there will be weakness of the triceps, weakness of the wrist flexion, and weakness of the finger extension. And there will be sensory loss in the middle finger, and the reflex that will be affected is the triceps reflex. In C8 nerve root compression, there will be weakness of the interossei and the finger flexors and flexor carpi ulnaris. There will be sensory loss in the ulnar border of the arm, and no reflexes are affected by C8 nerve root. In T1 nerve root compression, there will be weakness of the interossei muscles, and sensory will be medial aspect of the arm. That is T1. You can see here, this aspect of the arm will be affected, and it supplies no reflex, so there will be no reflex pathology in this compression. Then coming to special tests. Special tests are mainly three or four. So first will be spurling maneuver. There will be extension and ipsilateral rotation of the neck, should produce patient's radicular pain. So if you ask the patient to extend the neck and rotate it to the side that is affected, so the patient will complain of regeneration of the pain or symptoms. Hermite sign, it is mostly done in meningitis patient, but it can also be positive in these patients. So flexion or extension produces electric shock-like sensations extending from the spine and shooting to the limbs. Then there will be compression test, which we are supposed to press the head gently down when the patient is lying or sitting. This increases the radicular pain as there is decrease in the interforaminal distance or the intervertebral distance. So there will be increase in the radicular pain like this. So in distraction test, we evaluate the effect of traction on the relief of pain. Place the palm of one hand under the chin and other under the occiput and gently lift the head. The patient will say that his pain is reduced or disappeared completely. So for diagnosis, we are supposed to be doing radiology or imaging. So first will be always your X-ray. You can also do a CT scan. MRI scan is the gold standard. Or you can also do a myelogram. So in X-ray, so your normal discs will appear like this. There will be equal intervertebral disc distance or height, but in the degenerated disc there will be reduced intervertebral disc height. In MRI, you can specifically see which part of the disc is gone behind and is it pressing the cord or not. As you can see here, the disc has gone back and it is pressing the spinal cord. This is the transfer section. This is your vertebral disc. This is your spinal cord. So the disc has gone back and it is pressing on your nerve roots. This is your nerve roots. Same here, this is your nerve roots and the disc is pressing on the nerve root. You can also do a CT myelogram if the patient cannot undergo MRI. You can do a CT myelogram. You can see the disc that is coming behind. Coming to the treatment part. Whenever the patient comes, we are always supposed to treat the patient with non-operative management. The only indication of operative management on first day is a neurodeficit or a progressive neurological involvement. Otherwise, or a gallbladder involvement. Otherwise, all the patient must undergo conservative treatment. So first, the main part of the conservative treatment is rest, strict bed rest. You can give cervical collar. Then we can give ice for pain relief at the local site, anti-inflammatory agents, muscle relaxants, cervical muscle strengthening exercises after the pain goes away, and cervical traction can be tried with weight less than 10 laps. Operative management, the only absolute indication is increasing and significant neurological deficit or cervical myelopathy, or if there is failure of non-operative pain management. So surgical treatment, most commonly performed surgeries for cervical disc prolapse are cervical foraminotomy with excision of the disc prolapse. So foraminotomy is we go from the posterior part, we remove the lamina and we go into the foramen and we remove whatever the compressive pathology is there. We can also go from the anterior side and we are supposed to be doing anterior cervical discectomy with fusion. It is known as ACDF, anterior cervical discectomy and fusion. It is generally done when only one level of disc is involved. We can also do a cervical disc arthroplasty. It is not a very common procedure, but it is being done more and more in recent times. So the primary argument favoring this device is that adjacent segment degeneration is minimized. So when you do a fusion, the adjacent segment has to undergo more motion, so that undergoes more degeneration. So when you do cervical disc arthroplasty, there is no fusion that is being done, so the adjacent segment degeneration is minimized. Maintenance of motion is better with arthroplasty. Complications can occur, which include implant migration, heterotropic ossification, and recurrent radiculopathy. So that finishes our topic for the day. Thank you very much.